A moment of unimaginable joy is what a mother feels when her newborn baby is placed in her arms. A joy that every mother has the right to feel. However, in India, many pregnant women do not get this moment, do not have this memory, because this moment is shrouded in a lot of fear. Hello everyone and welcome to the Navin Times Talk from the Heart. Our guest today is Dr. Janhavi Nilekani, a development economist by training. She is now in the field of maternal health care. She has studied at Harvard and Yale and uses her education, her experiences to bring about change, much needed change in this sector. Coming from a well-respected, socially minded family, she founded Aastrika, an initiative of Nilekani Philanthropies. It's a pleasure to be speaking with her. Hello, Dr. Janhavi Nilekani, and welcome to our show.
Thank you so much for having me here today.
From development economics to maternal health sector, how did this shift happen? What got you so interested in it?
So please do call me Janhavi. And so development economics is microeconomics, right? It's the study. It is not macroeconomics about business cycles and so on. It's very much the study of how can the tools of economics improve human development. How can more people have access to education? How can more people have access to health? How can more people have access to opportunity? So maternal health and well-beings and reducing maternal and infant mortality rates actually is, I think, quite a big part of development economics. So how did it happen? Well, so I was trained. I'm trained in public policy. I'm a development economist with specializations by training in environmental economics and air pollution. I spent a lot of time studying and researching the impact of air pollution on public health and on reduced life expectancy. And then, so my actual PhD is a PhD in public policy from Harvard, and I'm choosing to apply that more on public health. So in 2016, when I was pregnant, I was still a student at the time, and I was toggling quite a bit between Bangalore and Cambridge, Massachusetts. Because I had to meet my professors and I had to spend some part of each semester in Cambridge, but partly my husband and I had just moved back to India, and also because the field work I was doing, a randomized control trial of 1,522 bus drivers to be specific, across 7 districts of southern Karnataka was very Karnataka based, so I needed to do a lot of field work for that. And I was pregnant, and I was very keen that my son is born in India. I mean, now I know he's a son, but the baby was going to be born in India. And though I had the option of giving birth in Cambridge, I was very keen. I didn't want to do that for a number of personal reasons. But I sought a lot for high quality healthcare in Bangalore or even in other urban cities. And it was quite hard to find, Unfortunately, what I was seeking was evidence-based medicine, that my healthcare would be based on clinical protocols, guidelines, and on the best quality global research on what should be done during pregnancy to have optimum healthcare outcomes for mothers and infants. And I was unable to find that in Bangalore. In private sector Bangalore, in the premium hospitals, it's very hard to find a place where cesarean rates are as per guidelines, episiotomy rates are as per guidelines, lithotomy, mobility, instrumental delivery. These things are not really the latest methods, and modern things aren't very followed. So what I could find healthcare-wise in Boston was really hard to find in India. And eventually I went to Hyderabad and had a fantastic delivery with a US trained midwife called Dr. Vijaya Krishnan of Sanctum. And that whole experience made me realize how much even the private sector, urban market in metropolitan places like Bangalore, where the quality of healthcare, maternal care is still not good. And then I spent more time studying it, looking at it across various income groups and so forth, and felt that post-graduation, I graduated, this was all 2016, I graduated in 2018 and really felt that for me, the time had come to move on from air pollution into maternal health, and that it felt like something I really passionately wanted to do. So in 2019, I founded Aastrika Foundation, an NGO which works on upskilling of healthcare workers across the country. We really, as a foundation, tackle a few things to reduce the infant mortality rates in this country, to reduce the maternal mortality rates in this country, to reduce the rates of cesareans in this country, which are very, very high in many, many parts of the country, and to ensure that every mother in India has access to what is called respectful maternity care. The idea that every woman has a right to privacy, confidentiality, a companion of choice, an abuse-free birthing experience. Disrespect and abuse during labor and childbirth is still quite rampant in many segments of society in India. And that is one of the major things that Aastrika Foundation tries to tackle. So in order to address these few things, we have a few programs. We run a digital learning platform called Aastrika Sphere, which is freely available to every nurse or ASHA or healthcare worker in this country. We have a lot of exciting partners from UNFPA, JPIGO, and Maternity Foundation. The platform is recognized by the Indian Nursing Council. So that is basically an effort to increase the skill sets of nurses and ASHA workers across the country in various states and government sector mostly, not so much in the private sector. We are also investing in a lot of programs around establishment of a professional midwifery cadre in India, and I can talk about that in more detail if you wish. And we are we also increasingly investing in physical training programs, including simulation and other methods. So, and advocacy. You know, at some level, we feel that until Indian women demand better maternity care, maternal health in India won't easily improve. That there has to be some consumer demand saying that I will not be okay with just accepting what is the quality of existing care. I want better. Right. So advocacy also. So this is sort of the overview of what we do and why I started to do it.
That's very intensive and very comprehensive what you've just told me. It's not just one area. You all are working on, in different spheres, and that's so amazing. Now, you have mentioned a lot of procedures which I'm sure even for me as well as for our viewers has gone over their head. You said I only got on to one, which is epistemology. You will need to explain that to us later. But we have got the gist of what you have said, that basically the maternal health sector requires a lot of change. It requires improvement. You spoke about the maternal mortality rate and infant mortality rate. Can you simplify it for us, please?
Sure. So the maternal mortality rate is considered as how many women die per 100,000 women having live births or giving birth, right? So in India, that all India number today is 103. So out of 100,000, 103 pass away. So that essentially is, it's sad, but in our country, out of every 1,000 births, one mother is lost. That is still a high number. It's not a small one. 1 in 1,000 is not a small risk to take on. Of course, it is geographically varies and so on, and I'm happy to chat more about that. But at the high level, it's 103 is the latest number. But on the optimistic side, it has come down a lot. It is still not the target. The target India is following is the Sustainable Development Goal of hitting 70. But it has come down a lot to 103. It was substantially higher 20 years ago was substantially higher, and there has been substantial progress from the central government, the state governments, public health, NGOs like ourselves. A huge coalition is working hard to reduce maternal mortality rates. Infant mortality rates is the number of infants lost per 1,000 births, and that number is currently 30. So that's actually 3%. 3 out of 100 babies. 30 out of 1,000.
Could I please interrupt? You said for the maternal mortality rate, it is 100,000. Am I right?
Yes.
And for
100,000.
For 100,000 births, live births, whereas for infant mortality rate, it is just 1,000.
Yes, it is 30 per 1,000. So that's 30%, right? Like 3 out of 100.
Absolutely.
Yeah, 3% of infants are still in India.
So which states, doctor, in India is this highest? Where is the infant mortality rate high, and where the maternal mortality rate, where is it highest? In which states?
The maternal mortality rates are highest in Assam, Uttar Pradesh, Madhya Pradesh, and Chhattisgarh. I don't have the infant mortality data off the top of my head, but are likely to be in the same places because those deaths are very interlinked. Places where the mother has good care, the baby also will have good care.
So those are for Assam and Chhattisgarh and Bihar, you said. What about Goa? What are the figures for Goa?
I don't know the maternal mortality rate offhand. The infant mortality rate in Goa is 6 per thousand, which is about 1/5 of the India rate. So that's definitely a really good number. I mean, I still live in 6 children dying per thousand. Obviously, we should try to further improve, but it is a good number, even by it's one of the top states, I think, on IMR nationally. I don't have the MMR number offhand, the maternal mortality rate number.
Right.
In Goa, almost all births take place in hospitals. So there are very, very few to negligible numbers of women still giving birth at home. Everybody does have access to healthcare in a facility. The cesarean rate in Goa statewide seems to be about 40%. I don't want you to quote me on that. I should double check it, but that is a kind of high number. The WHO used to say 10 to 15% should be cesareans, right? The WHO has backed off a bit and now says we don't know the exact number. There is research showing that after a state or a population crosses about 19%, it just becomes more surgeries with no benefit. 40% is a high cesarean number. I mean, Goa does have a fair number of unnecessary cesarean sections, where women could have had a lower risk vaginal delivery with less side effects, with a quicker recovery, but have had a cesarean for XYZ reasons. But the infant and maternal mortality rates are definitely good. So Goa is more of what we call a too much too soon problem versus the too little too late problem in a place like Assam, and I'm happy to chat more about that later.
Right. You just said too much too soon. What does that mean? How would you explain it in simple terms?
Yes. So India faces a dual challenge in maternal health, where healthcare tends to be either too little too late or too much too soon. So too little too late is when women have insufficient access to life-saving healthcare. As we spoke of Assam, Uttar Pradesh, Madhya Pradesh and Chhattisgarh, where maternal mortality rates are above average, where women are still dying, where infants are still dying at somewhat high rates. Those are often places where women either don't have access to the hospital, or if they do have access to the hospital, maybe there isn't enough skilled staff or good enough infrastructure or access to medicines, or even if there is, if they are referred to a tertiary hospital because their birth is going poorly, there isn't an ambulance to necessarily take them in time to save their lives. So it is generally called too little too late, and it leads to high infant and maternal mortality rates. The other side of the challenge is called too much too soon, which is too much medical intervention too soon before it is necessary, which is the kind of thing I faced in time, right? So we talk of high cesarean rates. A cesarean is a life-saving surgery, which can potentially, I think people know what a cesarean is, right?
Of course.
An abdominal surgery to extract the child. It is still a major abdominal surgery, and while it can be utterly life-saving in situations of need, there is a tendency in India to do it very casually, like, are you going for a normal or a cesarean? Without perhaps what I feel is proper informed consent about the risks to the mother's life, the child, the impact on the child's health, and the impact on future pregnancies, all of which become higher risk if you've had one cesarean, right? So it is, we do feel at Aastrika Foundation that there is an excessive use of cesareans, and many people feel that, including the government at many levels. The Karnataka government, for instance, or the central government, or the Telangana government. So in the past, the WHO used to say 10 to 15% should be the number at a state or country level. Even if it's not 15%, 20, 25, more than that is a bit iffy, right? Like the UK is at 27%. The US used to be at 33%. I believe it's come down a percentage or two. So Goa or most of South India has C-section rates substantially above developed countries because there are excessive C-section rates happening. In certain states, like in West Bengal, Telangana and Jammu and Kashmir, cesarean rates statewide in the private sector are more than 80%. That means more than 8 out of 10 women are having a cesarean in the private, if they go to a private sector hospital. In Karnataka, it is 52% in the private sector. I don't know the Goa division between public-private, but it's likely to be the same pattern is likely in Goa, where private sector hospitals have very high cesarean rates, whereas the government hospitals may not be as high. So too much too soon is things like this. Too much cesareans, too much of what are episiotomies. So the episiotomy is a surgical cut to enlarge the vagina for the baby's head to come out.
Right.
It is considered a harmful practice by guidelines. You know that all the research on episiotomies has indicated that routine episiotomies are harmful. I'd like to give you an example, right? Suppose you want to tear a piece of paper or a cloth. If I'm taking a craft project with my 5-year-old and I'm tearing a cloth, it won't easily tear. If I cut it and then pull it, it will tear easily, and that is the risk of episiotomies, that an episiotomy cut has a higher chance of extending into a severe 3rd degree and 4th degree tear based on research and guidelines. So as it shouldn't be maybe 10-20% episiotomy rates are reasonable, but in India it's 90+%.
May I ask a question here? You said that this cut is required so that the baby's head can come out easily?
No, I said the cut is done for the baby's head to come out easily.
Okay.
It is required in maybe 10 to 20% of cases. In India, it is done in 90% of cases, even when it's not required.
So it is the obstetrician who decides that this cut is required,
or the nurse, but they tend to do it as routine. In India, routine episiotomy is the norm. It is just done for everybody. There's no judgment calls necessary, but whether it's required or not.
So why does this happen?
So in the past, episiotomies were routinely recommended in the 70s, 80s, and so on. By the time of the 90s, enough research had come out and evidence that it was a harmful practice which was causing damage, and hence protocols changed globally, and then the US and UK and Europe and the developed countries therefore stopped doing it. But in India, sometimes we're quite slow to catch up to modern practices. It's very slow. It's not, episiotomies have been recommended against for at least 25 years. And there's been no change in India in these 25 years, unfortunately.
Right. You said that the maternal mortality rate in Madhya Pradesh, Uttar Pradesh, Assam is very high. What are some very important reasons for this, where change could come in and we could change the entire situation?
Sure. It's not easy to change. A lot of people are trying very hard, and it has reduced a lot. I want to start by saying that it has come down so much over the last 20 years that we have to also acknowledge our progress as a country, that maternal health, infant health has improved a lot. But there's a long way to go. I agree with you fully on that. So the proximate causes is that a lot of the deaths are happening from some type of hemorrhage, like postpartum hemorrhage, antenatal hemorrhage, antenatal hemorrhage, severe anemia. Postpartum hemorrhage remains the leading cause of maternal mortality globally. But that is just a proximate cause. It's actually happening because they're not getting enough prevention of postpartum hemorrhage or enough treatment for postpartum hemorrhage, right? Because if you have PPH in a Bangalore hospital, like where I'm sitting right now, you will get treated immediately. Your life is very likely to be saved. So yes, hemorrhage is the cause medically, but the larger cause is that they have insufficient access to high quality to healthcare, right? So prevention, ensuring everybody has an oxytocin shot, active management of leave the technicalities. There are some prevention methods which are promoted across the country, but maybe I don't know the rates that I wouldn't want to say I don't know enough about the implementation rates of these techniques. Malnutrition is a challenge across our country. Women are malnourished. Anemia rates are very high in India. So when you are low on iron, then it is easier to hemorrhage in a very serious way. So, malnutrition it's a life cycle thing, right? Like you have to go back all the way back to so these are, and hypertensive disorders, high blood pressure, gestational diabetes rates are quite high, especially in urban India. So those are I wouldn't say. Okay, I don't want to go too much into technicalities, but at the highest level, that there is still a lot of preventable maternal mortality in India, which could be addressed by the kind of things Aastrika Foundation seeks to do. Ensuring that every healthcare worker in the country is very skilled to deal with emergencies. So that includes knowing exactly what to do in a drill. Like your PPH, you don't have to go around thinking, oh, what did my textbook say? Drill. I know what to do. This is a PPH. Ensuring equipment readiness. So on our learning platform, Aastrika Sphere, as an example, we have one course from NSSK, which is a lot about equipment readiness. Your delivery tray should have everything you need. You should not be scrounging around last minute saying, where do I get the whatever I need to address this PPH, right?
And this does not happen, doctor, this does not happen in most places. That equipment is ready so that they can do the procedure that is required in case of an emergency, right?
I don't want to say that it's not there in most places, but perhaps it needs to be improved nationwide to really bring down the maternal mortality. This is one of the things that needs to be improved nationwide to bring the maternal mortality rates down. Another challenge is just upskilling everybody across the board, which is a lot of what we do, right? When we talk of simulation training, skills training, theoretical learning online, all of those are ways to increase the skill base of our healthcare workforce. Referral systems are a challenge, and that is not, if it's a PHC in rural Bihar, for example, even if they've identified that the mother needs to be referred to a tertiary center, that referral may not happen on a timely basis, right? I mean, there may be no way to get that mother from this rural primary health center to the local district hospital in time, right? From my understanding, but here I'm not as sure, I've just heard it, I haven't looked at data, is that the difficult terrain is a challenge, especially in places like Assam or Chhattisgarh or Jharkhand, areas where it's not like Bangalore where I get into, okay, Bangalore also you can barely move 20 minutes in Bangalore, so.
The traffic.
The traffic is atrocious, but still there are enough hospitals that you can go to the nearest one. But there aren't that, in Chhattisgarh or in Assam, you are driving hilly terrain, you are struggling a bit, and referrals not happening in time can be a challenge. I mean, we need to improve antenatal identification of high-risk mothers. If you know who is high risk, you encourage the high-risk mother to birth in the district hospital in the first place and not in the PHC. So people are working on all of this. Things are steadily improving. If you look at actual graphs, MMR is dropping across India. So I don't want to sound despondent, but the cesarean rates are going in the wrong direction. MMR is improving.
That's heartening.
Problem is going badly.
That's heartening, to hear that those rates are falling. But like you said, with initiatives from people like you and from foundations like you, I'm sure the change is going to come about. It is slow for sure, but I'm sure it's going to be there sooner than later. So my next question to you, doctor, is that you spoke about some of the fundamental rights of childbearing women. We know we have fundamental rights. We have the right to speak, follow our religion, so on and so forth. But for a woman, for a childbearing woman, what are her fundamental rights?
So when we talk as Aastrika Foundation of the fundamental rights of a childbearing woman, we are not talking about it so legally, right? We're not talking about it deriving from the Constitution as such.
Right.
These rights have been sort of outlined in a charter called the Respectful Maternity Care Charter, which is endorsed by many bodies, including Aastrika Foundation, and is a global charter which derives from rights in the UN documents and the other documents which were signed, in the 40s and 50s, and the universal rights of the child, the universal rights of the woman. So they are derived from those, but in a day-to-day way, they have been enlisted as roughly 7 points. Essentially, they are the concept that every mother has a right to privacy. What often happens, and it is very sad, I've seen pictures of it, is that it's a labor ward. There are many women. People aren't given a curtain. There's no privacy. Nobody's given a blanket. You are, bare of clothing from the navel down.
Yeah.
And it's like a line of women like that. That people have a right to privacy. I'm not saying a constitutional right, but a right to at least the decency of a blanket to cover them, right? Unless they're actively giving birth, but not for hours on end. And the doors are open. People are passing by. There isn't a right to confidentiality. If we, like one of my colleagues says, it shouldn't be like, oh, okay, that HIV woman in that bed over there. Patient confidentiality should be respected. People have a right to that. People have a right to an abuse-free birthing experience.
Now that, doctor, sounds very ominous, The right. Yes, please tell us more about that.
It is very sad, but what is called disrespect and abuse in labor is rampant in most of India. So things like slapping the mother if she's making too much, shouting too much, pinching the mother. It is quite common in labor rooms across the country and across the world, right? Not in the premium hospitals in metros like Delhi, Mumbai, Bangalore, but even in Mumbai, Delhi, Bangalore, I know personal anecdotes from my friends that if you're 3 cm, the nurse is saying, you're making so much fuss now for this much, I mean, how are you going to cope only 3 centimeters? That's not verbally abusive, like what happens in perhaps low-income segments, but it's not exactly compassionate care. It's not compassionate, woman-centered care. A mother in labor or a to-be mother in labor is at one of her most vulnerable moments in life.
Absolutely.
As a society, as human beings, we should be having compassion, and sadly, as a society, we don't seem to. Right? So, physical abuse like pinching, slapping, stuff like that, which definitely happens. Verbal abuse is perhaps even more common, where very like, and in crude language, I won't say it, but when you are getting pregnant wives making such a fuss now, but in much
cruder language,
much cruder language than that. So that kind of stuff is fairly common. I have vetted it with many people, and they're like, this is what happens in the training, in like places where. So discrimination based on caste and class and so on is one of the things which respectful medical care tries to avoid. We say that every woman has the same right to healthcare. You should not be looking at her caste, her religion, she has that same right to healthcare as anybody else. Right? Whereas, of course, healthcare in our country is totally all over the place based on your caste, your community, your background, your locality. There's no doubting that. So all of these things, the presence of a loved one. In the WHO Safe Childbirth Checklist, one of the first things is the presence of a companion during birth. And that is considered a best practice around the world in all guidelines, including the government's guidelines. Through Lakshya and all say a mother should have one birth companion, her sister or mother should be with her. She should not be left alone in this room of 20 women without even a blanket to cover her personal areas. It is a hostile environment. It is frightening. It is not. In the past, women birthed at home with other women around them, with loved ones around them. And I am 100% pro the move to institutional delivery. Do not get me wrong. I am happy that India now, most people give birth in the hospital where they have access to healthcare. But when they birth, that moving mothers to an hospital is an intervention, and it is often an unpleasant one, right? Some of the reasons we have in tribal areas and some of the reasons we have some women avoid coming to the hospital precisely because it's abusive. You may have a higher risk of passing away at home, but you will not be stabbed, pinched, made to display your parts in front of like whoever's walking by. I mean, it's not a pleasant place to give birth, and it prevents health. It's wrong in and of itself. It's wrong to treat people like that. It is worse because it prevents health-seeking behaviors. Right? People then say, I'll take my chance. My chance of dying is still only 1 in 100 in 100,000 or 1 in 1,000. 999 chances I may be okay and I will not be slapped, pitched and abused. So,
right. You just said that the woman has a right to have a companion. It could be her mother, it could be her sister. Does it always have to be a female, or can her husband or partner be with her? Because in the metropolitan cities, we have the husband is allowed into the labor room.
Yeah, I mean, we were talking in the context of large labor wards of
right.
government hospitals. Those, I think, are unlikely to
allow the husband.
I mean, some of them do, I believe, but only the places where each woman has a curtain. The problem is if you have 20 women in a row, then it's a strange man for the other women, and hence they say, I think most
True.
of them say only women.
True.
But of course, in the private sector, husbands are allowed. I mean, Aastrika Foundation has spun off a separate private sector midwifery center in Bangalore, where I'm sitting right now, and of course we allow men, and so do all my friends have their husbands at their birth, right? It's of course in many segments of society, yes, of course men. It's more I'm talking about the large labor wards in a busy government hospital. When
okay.
I said that, yeah, definitely
okay.
men as well.
Okay. It's time for a break, a very short break. Don't go anywhere. We'll be back soon. Welcome, everyone. You're watching the Loving Times Talk from the Heart. We are in conversation with Dr. Janhavi Nilekani, who's telling us about the mental health sector in India. Doctor, you spoke about the number of cesareans are on the rise. Why is this happening? With so much of progress in the field of medicine, this number should have been going lower and lower every year. But you are telling us otherwise. What has led to this?
Okay, I don't know if I would say it should have been going lower and lower every year because there hasn't been much global innovation in avoiding cesareans, right? But I do think that ideally the cesarean rates, at least in developed states, would be stable. But instead it's rapidly climbing, right? So to give you just the speed of the rise. In NHFS 4 in 2015-16, in the private sector, Karnataka cesarean rate was 40%. Within 4 years, it's 52%. That's the speed at which it's shooting up, right? 80% plus in multiple states is a very bad number. Telangana's statewide number is 62%. Kerala's statewide number is 42%. This is against the United Kingdom having a 27% cesarean rate, right? We are very much underperforming developed countries on this matter. So why are cesarean rates so high and why are they going up? There are a whole range of reasons. Part of it is cultural. This has become very normalized, and I hope that channels like yours and this kind of show, mothers should question a bit at least. We shouldn't blindly accept it without some discussion of why you recommending cesarean to me. Is it a necessary cesarean? Especially in the private sector, I do think it is important for mothers to themselves be questioning and asking why. Of course, financial reasons, it is more cost efficient for hospitals to do a cesarean, substantially more cost efficient to do a cesarean, right? Especially scheduled cesareans, which can be done 6 in a few hours, are easier, let's be honest, for any hospital or a doctor.
Right.
Much easier. Natural, normal labors can typically go on for 8 to 24 hours, right? A normal labor, a normal delivery. And unfortunately, that entire 8 to 24 hours, the doctors and all have to be on call because any moment it can become an emergency. So, to do vaginal deliveries in safety, you need 24/7 presence of obstetricians, pediatricians, anesthetists, and that is something which is cost inefficient for many hospitals. I think they find it easier to reduce the number of hours where they're fully staffed, and therefore that leads to more cesareans. That's my understanding partly. Definitely, it is easier to. Cesareans are more daytime surgeries, again, daytime work, right? Less as night shift work, and that again is something simpler. So there are reasons around finances as well as convenience factors. But I would also say that a lot of it is a very genuine belief in risk. So I think some substantial erosion of skill has happened among obstetricians in India, because just 20 or 30 years ago, there weren't this many cesareans. 15 years ago, it was much less, right? Now, the same doctors have been practicing to some extent. Somebody who's now in her 50s was practicing 20 years ago. In the meantime, the cesarean rates have shot up. But as you do more and more C-sections, you forget, frankly, there is some skill erosion in how to manage tricky vaginal deliveries. The completely low risk, very easy, they come and the baby just comes out very quickly is one thing. But I find that even with the slightest amount of challenge, people seem to be toggling to a C-section versus managing a slightly challenging vaginal delivery. Is my understanding. So it's multifaceted. Younger obstetricians may not even be getting the training they need on vaginal deliveries, right? I know that for sure that Fernandez Foundation in Hyderabad had a midwifery training program, and it was a pilot done with UNICEF and the government of Telangana, and they opted to do it in a district hospital which had like an 85% cesarean rate, thinking that this is the place which needs midwives, which needs the restoration of normalcy. But unfortunately, because 85 to 90% were cesareans, they barely had any cases on which to train the midwives in vaginal births. It was literally like that. So some of it is skill erosion that's happening for sure. And families have become very fearful. There is a conception, and I'd like to talk about this for a moment. There is what I think is a misconception among Indian families that a cesarean section is safer. A cesarean section is safer if you have some problem, maybe. For a low risk mother, no. I mean, numerous risks to an elective section, up to and including the chances of maternal death are higher, right? If you look at the actual indicators, there is recovery time is worse. It's sometimes harder to establish breastfeeding. The downsides of a cesarean are quite high, but even families seem to have this mindset that it's safer. But it is not safer. I have not understood why Indian families necessarily think cesareans are safer. But that is a very widespread cultural perception, which I have not fully understood. But so it's a very multifaceted challenge, I would say.
So you are saying that the mother too should be a part of that decision of having a cesarean? Is that what you're saying, doctor?
Yes, I do think so. I mean, I am very much a proponent of what we call empowered birthing and shared decision making and informed consent. Obviously, if it is a critical emergency, like life and death in a matter of moments, then please defer to your obstetrician. But most cesareans are not like that. Most cesareans are either you're having a discussion in an antenatal visit, like an OPD basis, or it's like you've been in labor for 6 hours, nothing is happening. Shall we?
Right.
You've been able for 5 hours, nothing's happening. Shall we go for a cesarean? Those are not emergencies. And in non-emergency situations, I believe there should be a proper discussion between the family and the doctor of the risks of the cesarean, the benefits of the cesarean. What is your alternative to cesarean? If I wait 2 more hours, do you think I might progress and have a vaginal birth? If the doctor says, yeah, if 6 more hours you wait, you might have a vaginal birth, then the mother should be able to say, no, I'm okay to bear the pain, I'll take pain relief, but I don't want to go to the OT. Give me laughing gas.
But realistically, doctor, when a woman is in labor, she is in so much of pain. When the doctor tells her this can go on for another 12 hours or 15 hours, I think there are, in some cases I've seen myself, where the woman says, I can't take this anymore. Just let's just have the cesarean and finish it off. Also, she's in so much of pain, she's not thinking right. So for her to question her obstetrician and ask questions, first and foremost, not all obstetricians, I'm sorry to say this, are very kind and accommodating. They will not answer your questions. They just say, I'm the doctor, I'm telling you it's dangerous. Then the family members are all getting hyper. So this is a normal scenario. For a woman in a situation like this to say, what are my options? She, believe it or not, she's not in that state. She's in so much of pain, right?
So I would like to comment on that. First, yes, but I am not necessary. You may not have much decision-making power in the labor room, but you have decision-making power early on your pregnancy on where you choose to give birth, right? Which hospital door, even in the US, statistics show that which hospital door you walk into is the biggest risk factor for cesarean over and above anything about you and your baby. The number one risk factor for cesarean is where you give birth. There is that much divergence across facilities of cesareans. We run a private sector hospital. We have a cesarean rate of 30%, right? Statewide Goa is 40%, private sector Goa is 50%, statewide Karnataka is 50%, Jammu and Kashmir, Telangana, West Bengal private sector is 80+%. There is a huge range from if you're 30 to 80. You may not be able to you may not be able to advocate for yourself in labor, but you can advocate for yourself with your family beforehand on which doctor you choose. And there are good doctors, there are doctors who are more ethical minded, there are doctors who are still striving to sustain good vaginal delivery rates. Ask around wherever you live and you may find an excellent doctor who is not very well known but has good outcomes, right? So that is one. You have that power. You always do in the private sector. I'm not talking of the government sector. You're at the end of the day, you're a paying consumer. You have a complete right, the way you choose your cars, the way you choose your wedding venues, the way you choose your bridal sari, you can choose your doctor. It is not an emergency pregnancy. If I'm having a heart attack, I'll go wherever. You have 9 months to select a doctor. You have time. That's my first comment.
Right.
Secondly, one thing I find very sad in India is that pain relief is withheld. And very frankly, and this maybe I shouldn't be saying this, but very frankly, cesareans are offered as a pain relief mechanism. I really believe that no cesarean should ever be done for either impatience or lack of pain relief. In the center, Aastrika Midwifery Center, what we run as a private sector spin-off, we have every pain relief method on the market. Even in the US and the UK, women are not suffering for hours in pain when they're all having vaginal deliveries. They are opting for pain relief. In India, women are not allowed to have pain relief or are not offered pain relief, and then are encouraged to go for a cesarean. That I find it very unethical and sad.
So, what are these pain relief solutions that you're speaking about? Can you expand a little on that, please?
Oh, yeah, sure. Sure. Okay, in the public sector, I don't want to comment here about the public sector so much because I know there are other constraints there around pain relief and so forth. And in the public sector, they are not typically doing cesareans for lack of pain relief anyway. So let me drop that. Talking of the private sector, mothers are confined to their beds, even though movement is itself a form of pain relief. Companionship during labor is one of the most evidence-based forms of pain relief, and it is not allowed. In Bangalore, I think Aastrika Midwifery Center is the only one that allows doulas into the hospital, professional birth companions, right? Movement during labor, I don't know, I'm actually in a birthing suite. We have birth stools there to sit on, birth balls. We have a water pool there, water immersion. I mean, you can there's a peanut ball. So we have a whole range of what we call non-medical options. Hydrotherapy, do you want a shower? Water immersion is one of the most proven and solid non-medical pain relief methods with minimum side effects, the water tub I just showed. In the medical method, there's laughing gas. I always promote laughing gas. There's almost no hospital that I know of in Bangalore offers it for birth. But laughing gas has minimum side effects and you get at least some pain relief. Opioids like pethidine and so on, those work. They have certain side effects. Epidurals work. So pain is not a reason in my view for a C-section. It's like saying that, I don't know, but if you have pain, then give pain relief. Why are you taking the decision that a woman has pain and therefore let's take her for a major abdominal surgery? It's not appropriate.
So basically what you're saying, cesarean should be the extreme choice, the final. Only when all the other options are explored, it's only then that a woman should go in for a cesarean.
I mean, I don't know if I want to say that rigidly, but definitely I think that it should not be seen as a choice, like a 50-50. Am I going? Oh, have you booked? Like when I tried to hire a nurse for baby care in advance, she said, "Oh, are you going for cesarean or normal?" And I was like, "I'm going for normal. If I have a medical reason, I'll go for cesarean. I'm not taking it like candy to go have a surgery without need, right?" So that's one. And definitely, even doctors or hospitals should first try to. I'm a development economist, right? So and this is my view. I mean, others may disagree. Economics is the study of how do we overcome scarcity? How do we do decision making under uncertainties? This development economics is about being at the frontier of human knowledge. So I feel for anybody, how do we get the best health outcomes for mother and child with the least side effects? And that is not having cesareans for everybody, right? Yes, it's a few hours of pain. I mean, I had an unmedicated vaginal birth. I didn't even have laughing gas or anything, or a water tub, nothing. And many mothers at Aastrika Midwifery Center opt for that as well. And undoubtedly, it's a few hours of labor pain. But when you're not fearful, when you're in an atmosphere of support, of encouragement, of love, and an oxytocin-rich environment that the love hormone is going up on its own, it is. We say at Aastrika that pain is okay, suffering is not. Even if you're having labor pain, if you're coping with it, if you're confident, if you're progressing well, it's okay. You know it's for a purpose to meet your child with the minimum side effects. And then afterwards, you're up and about in 2 hours, yeah? Our very first birth, the mother gave birth in the water. And then 15 minutes she did skin to skin, cuddling the baby, nursing. And then she got up on her own, shampooed her hair. Then she put conditioner, which I was also feeling was a bit much because the baby was crying for milk and I was like, shampoo is okay, do you really want to condition her? She says, yes, I'm going to condition my hair. And then she walked to the bed and gave her mother, breastfed her daughter some more. I mean, that for me was always worth the few hours of pain, and I was up and about in minutes, or I see that all the time. It is, to get back to your life and your physical life quickly, for me was worth the few hours of pain. People may disagree, but I feel that option is not even considered in our country, that is worth it. You know?
Right. Now, you have been speaking a lot about your midwifery initiative that you have at Aastrika. Can you tell us, first and foremost, who exactly is a midwife?
Sure.
What are the qualifications to become a midwife? And how do midwives benefit society generally?
Okay, three parts, right?
Right.
Who is a midwife? So, professional midwife, when I say midwife, I'm only talking about professional midwives. Professional midwives are not what is known as traditional birth attendants or DIs, right? When
Okay.
we talk of midwives, we talk of midwives who are educated in a modern system of medical care and very much part of the medical healthcare system, right? So, a midwife is a healthcare professional who has received specialized training in looking after mothers and babies. That's the simplest definition. The International Confederation of Midwives has a very specific definition, which is a very technical one. In India, a midwife is a person who has completed 3 to 4 years of nursing education, has some labor room experience, and has finished a 1.5 to 2 years master's equivalent postgraduate specialization in midwifery. So it is a person who has been through, after having gone through nursing college, etc., has also gone back and done a postgraduate specialization in midwifery.
So this
That
is
is
about
what
4.5 years in total?
5.5 typically. A
So
BSc
4
nursing,
plus one
a
and a half.
BSc is 4 years, a GNM
Okay.
is 3 years, so there's some
Okay.
up down there and
Right.
very
Right.
much varies by state. But let's take it as 4 years. A BSc nursing, ideally 1 to 2 years of work experience and 1.5 years or 2 years of, there are 18-month and 24-month programs in midwifery in India, specialized training. This is very different from an old school perception of a midwife, like a DI or a traditional birth attendant. I'm not talking about that. I'm talking about people who are trained in the modern system to be somewhere between a nurse and obstetrician with specialized skill set in birthing.
Okay. So what is their role? How will they benefit the mother, the child?
Yeah. Aastrika loves midwifery and midwives, and we promote them as a foundation very widely. In fact, a lot of our initiatives are on how do we establish a cadre of professional midwives in India, right? Along with many, many people, central government, state governments, Bill and Melinda Gates Foundation, WHO, UNICEF, Fernandez, Japaigo, a lot of people are involved in that. Midwives are a solution to the too much too soon and the too little too late problem.
Right.
Because midwives have that specialized 1.5 to 2 years training, they have that quality of knowledge that even in rural areas or in underserved areas, they can reduce the deaths from too little too late.
Okay.
At the same time, because they are specialists in normal birth and not in cesarean sections or surgeries, they can address the too much too soon problem because they are literally specialists in how to use a birth stool and a birth ball and a peanut ball and compassionate care and how do you get births to progress normally without opting for a cesarean. At some level, they are not surgeons, and hence surgery is not even in their toolkit, and then midwives are therefore stronger perhaps in non-surgical resolutions to birthing challenges, I think I would.
Okay.
If right, because they're not surgeons, so they can't take that hammer
Right.
for the nails. They are forced to have nail specific solutions for all the things that can crop up in labor. So they're specialists. So they basically address both sides of the problem, and we feel they're very critical in India, and they will help society by ensuring, by contributing, not ensuring, towards lower infant mortality rates, lower maternal mortality rates, while still stemming this epidemic of cesareans.
Okay. So have you seen a rise in the number of people taking up midwifery?
Yes, both seeking midwifery as well as start training as midwives, yes. Because India is making a solid push. The government of India launched the guidelines on midwifery services in December 2018. There is a substantial program around it nationwide, and yeah, of course, it is working quite well so far.
So
COVID
what
hit
is
it badly, but it is still working.
so what is Aastrika doing to take this forward? Besides having your classes, you have online classes, you have training. Are you all also sending midwives out in the rural areas, in the remote areas, to help pregnant women, expectant
That is a
mothers?
long-term plan, but India has very few professional midwives at the moment. The training programs are very nascent. There may be a couple of hundred of them at this point.
Okay.
Moreover, they are employed by the government largely. So the government deploys them as they feel is the need, right? We have only. So the current immediate step is we are partnering with the government of Karnataka to establish a national midwifery training institute at Vani Vilas Hospital in Bangalore, Karnataka's largest mother-child facility,
Okay.
which will be a training site for midwives. That program has not started yet. We hope to launch it soon. Once they are trained, they may then be deployed in rural areas. But right now, the need of the day is to train many more midwives first.
Absolutely. If you were asked, can you give one solution to this problem whereby we can bring our MMR lower? What would you say would be that solution? In your opinion, it doesn't have to be what what others have to say, it's just yours.
One solution.
Okay, you want to give
No,
three?
but
Please
it
go
needs to be
ahead.
one word. It doesn't need to be one word.
No, no.
See, I could have talked about midwifery, I could talk about skilling, I could talk about better infrastructure, but if I have to say one solution to reduce maternal mortality, to reduce infant mortality, to reduce cesarean rates, to reduce disrespect and abuse, women in India need to ask more of the healthcare system. They need to ask more from their doctors. They need to ask more support from their families. They need to ask more support from their in-laws. There has to be, our culture has to change to say women are worth it, that birthing experiences matter, that leaving mothers with traumatic birth experiences is not okay, that spending large amounts of money for not getting modern evidence-based treatment is not okay. Until the day that we as women in India stand up and say this needs to change, things won't change. So that would be my number one solution.
You spoke about evidence-based intervention, evidence-based technology, did you say?
Medicine, I think, or skills.
Medicine, skills, okay. What does that refer to?
I mean, if WHO or international guidelines suggest that cesareans should be 20%, and you have entire states where statewide numbers in the private sector
40 and
50%.
50.
40, I mean, 40 is your statewide number in Goa, but if you take, let's take Telangana, right? The statewide number is 62%, the private sector number is 80 something percent. Out of 10 women, 2 are having a necessary 20%, right? So 2 are having a necessary cesarean, 2 are having an appropriate vaginal delivery, and 6 are having an unnecessary cesarean, if you look at those guidelines. So women have to question also, right? And stand up and say, it's not okay for me to do this. I'm not going to, I mean, I'm going to go look for who are the good doctors, who are the ethical doctors, who are the ones who are going to ensure they give me highest quality treatment. Until consumers and clients and women and mothers say that we will go to the best doctors and we will strive and we will try and we think we should have good treatment and not just accept the state of affairs, things won't change easily.
Absolutely, but that would happen mostly, where they question, where they ask questions, is something that would happen in the cities, in the towns. But in the villages, do you think this would happen? Do you think this would happen soon?
In the villages, most births happen in PHCs, CHCs and district hospitals.
Right.
But I would actually say that the government is doing tons of work to try and improve those systems, right? So take it initiatives like Lakshya from the government side to improve quality of care in labour rooms, or Suman, or equivalently the whole professional midwifery services, December 2018 launched guidelines from Government of India, is a government health system program. So the government systems, I can at least say a lot is happening already, with or without whether the women in villages are demanding better. There is a strong pressure from all segments to improve the healthcare for them. Whereas in the private sector, because it's a consumer market, it hinges a lot on consumer demand.
Right. So how do you see Aastrika Foundation moving forward? What are the plans that Aastrika has to bring about more change?
Oh, we're very busy. It's quite exhausting. I need a break. That's why I'm coming to Goa next week.
Great. So then we are going to see you. We'll see you soon.
Our goal for our learning platform is to hopefully one day touch every nurse and ASHA worker in this country. We are piloting a new program for ASHA workers in 8 states. My team is constantly running around to 8 states, right? We just launched with Japaigo a program on Dakshata. We have endless new trainings coming out all the time. We encourage uptake. Anybody can log into sphere.aastrika.org and avail of any course in maternal and neonatal health from top-notch public health institutions, right? So that's going on. We are, fingers crossed, really hoping for this National Midwifery Training Institute at Vani Vilas to start soon. That's a major program, right, where we are on the ground. We are working on things like simulation labs. We're working on advocacy. We are working on a lot. In the private sector, we've set up Aastrika Midwifery Center to have an understanding of the private space. I'm very tired out. We do a lot. You can.
Good.
Would love
so you need
to
that. So you need that holiday in Goa.
I need the holiday in Goa. I'm reaching on Tuesday morning.
Great. I think that's all from us. Thank you so much for answering all our questions. and you have given us a peek into the change that can come about. And thank you so much to all our viewers. Thank you for watching. Thank you for your time and for your attention. Until next time, take care of yourself.